allocated time. We've allocated time at the end of this meeting always to respond to questions received in advance from members of the public. We have 7 members of the public signed up to attend. Welcome to you all, and no questions. We have apologies from Dr. Hugh Thomas, and we are quorate as a meeting. Can I take us to the conflicts of interest register and declarations of any interests new or relevant to this meeting? None. Thank you. And I'd like us to look now at our minutes from the last meeting, which was held in public on the 18th of April, and the matters rising. Can I have any comments on accuracy or any issues that are not covered from matters arising? I'm just scrolling across my screens to be sure to see whether I have any hands up. No, I don't. May I take those minutes as accurate? Thank you. We're going to move then, first of all, to our Chief Executive, Fiona Edwards' update. Over to you, Fiona.
Right, good morning, everyone. Well, it's been almost a year since the Integrated Care Board was established by law, the 1st of July last year, and what a year it's been. We've seen continued dealing with surge in demands and the pandemic, and also a huge amount of change and turbulence, both in the construct of integrated care boards and the National Health Service, but also in our whole way of working. So it's been a year of highs and lows, I'd say, and very recently, since we last met in public, some real positives and some real negatives. So we had the announcement of the new hospital for and the investment being allocated for Frimley Park. Neil's on the call, and probably the celebrations feel a while ago, since huge demands and on the service, and the industrial action last week that our colleagues, particularly in the hospital, but also in the system, have had to work and respond well to. But it is great news for our residents that we have the commitment to fund the new hospital for to replace Frimley Park, and obviously that work is now being established and set up in order that we can enmesh it to best effect within the wider ecosystem of service delivery to support our population. We had a really challenging weekend with a surge in the heat last week and the weekend before last, and with the consequent impact on people with regard to pollen and upper respiratory, which led to really high attendances in our emergency departments, not only in the Frimley system, but more widely. So again, just to illustrate the challenges, and then leading straight into a week of industrial action. But part of the highs of our work is we're celebrating the fact we've had 2 significant clinical leaders receiving honours. Lalitha might want to say a little bit of words about Dr. Priya Kumar, and then Neil might want to say some words about Prem. Lalitha, do you want to just let the public know about Priya?
Thank you. Dr. Priya Kumar is a GP partner in Slough. She has been working relentlessly on tackling health inequalities at a place level, but also links really well with opportunities at what she can help with as a system. So she has been awarded the honours work for her work during COVID, but has also been working specifically with communities in Slough where there are multi-generational families, and she has enabled the reaching out that clinicians and health and care sectors need to do into these families. I'll hand over to Neil.
Thanks, Aletha. Sorry, I'm having a few problems with my video, but yes, we're delighted that Prem Premachandran has been honoured in this way. Prem's a bit of a legend of Frimley. He's been with us a long time. He is a consultant in emergency medicine and developed and built the new ED at Frimley Park, and then subsequently developed the emergency assessment centre at Wexham Park as well with the teams as well. And he's led a lot of the urgent care improvement work. And more latterly, he's been doing that on a national basis, leading the work on behalf of the Care Quality Commission and improving urgent emergency care across the country as well. So he's a fantastic individual, and we're incredibly proud and pleased for him receiving this honour.
Thanks, Neil. And we also have 6 shortlisted nominees in the Health Service Journal National Awards, which is the trade industry awards in the NHS and with partners with social care, really highlighting our fantastic work, both in terms of data and analytics, but leading in partnership with clinicians to innovative focus around addressing health inequalities. So good luck to all those that are shortlisted for the awards that take place this week. I think it is, Lalitha, isn't it? Yeah. So those are the highs, but that is set against a backlog of really working hard and struggling to address the recovery of our waiting lists, to respond to surges in demand, to support providing services in the midst of industrial action. So the risk of exhaustion and disaffection amongst our staff across both health and care is very high, and it's just amazing that people are still keeping going and still working their socks off. So that's the context with which we hold the public board today. So back to you, Priya. Chair, sorry.
Thank you very much. Any comments or questions for Fiona? Thank you. Let's move then to our first item from our strategy and planning section, which is our 5-year joint forward plan. And I'll hand now to Sam Burrows. Thank you, Sam.
Thank you very much. I want to ensure we've got sufficient time for discussion of this item. So I won't be sharing any slides, and I will rattle through my introductory remarks relatively quickly. These papers have been available in the board bundle since last week, and I know members will have familiarised themselves with content already. There are two products in your papers. One is the draft joint forward plan, which is presented to the board today for approval. And the other, recognising the length of that joint forward plan, is a summary document which was produced for all considering boards, which gives you the highlights of the plan as a whole. By way of background, to ensure that members of the board fully understand why we're considering this today, the requirement to produce a joint forward plan is a new requirement set out by the Health and Care Act 2022, which you'll recall was given royal assent around about a year ago. It sets out the need to produce a 5-year plan jointly between the NHS partners within an integrated care system. For the avoidance of doubt for this board, those NHS partners as described by the legislation are Frimley ICB, as we are meeting today, Berkshire Healthcare Foundation Trust, Surrey and Borders Partnership, and Frimley Health Foundation Trust as well. All 3 of those other organisations have already considered the joint forward plan at their boards prior to today. The 5-year plan is required to be refreshed annually on a rolling 5-year basis, and the legislation requires us to publish and produce this by the 31st of March of each year. However, this year is the exception to that requirement, recognising that the new statutory bodies as set out by the Health and Care Act only came into being on the 1st of July 2022. It sits within our ICS strategy as a frame. We've considered the ICS strategy as approved by the Frimley Integrated Care Partnership at one of our meetings previously, and the joint forward plan sits within that as described in the papers. I would like to just highlight a couple of additional things by way of process. So it is presented here today for approval with an intention that approval be received to publish by the deadline of the 30th of June. We are also required to seek opinions from the health and wellbeing boards within the geography. In Frimley, this is not necessarily a straightforward task, given that there are 5 health and wellbeing boards within the ICS footprint. During the period of drafting and creation of this document, we had a pre-election period that ran from the middle of March to the beginning of May. And since the local elections held on the 5th of May of this year, 3 of our local authorities changed political administrations and therefore have not yet been able to meet as health and wellbeing boards prior to our meeting today. We are absolutely committed to meeting all of our health and wellbeing boards when they're able to meet collectively and individually, so that we can have that discussion with them. Clearly, that wasn't able to be done prior to our meeting today. In terms of the content of the document, it really sets out 4 separate pieces which should be considered together. Firstly, there is a significant degree of detail around our service development priorities. These form the basis of how we want our services to evolve and meet the needs of our population over the next 5 years, and will also provide the foundation for a refreshed clinical and service strategy produced by the system partnership as a whole. Secondly, it sets out how we will use our resources to best effect. We use the term resources in the broadest sense here. That includes our finances as allocated to us by NHS England and the government, how we use our digital and data architecture, how we make best use of our estates, and most importantly of all, how we support our people in delivering services to our population. The document also sets out how we will work better together in partnership, whether that's through our formal means of provider collaboratives, places, ICPs or ICBs, but also how we will work together in the delivery of the priorities set out in the document. And finally, it provides clarity on what our year 1 priorities are for 23-24, which are a direct read across from our 23-24 annual operating plan as already submitted. All of these elements are aligned with our 2 strategic objectives to reduce health inequalities and to increase healthy life expectancy, as set out by our ICS strategy. You will also see in the document where there is significant alignment with the national programme, or called Core 20+5, around seeking specific improvement in the reduction of health inequalities. In terms of next steps, clearly there's more work to do. If the board is able to approve the document today, we would like to start a new phase of communication and engagement and conversation with our public and broader partners. Clearly, the document that we have today for approval requires some additional work in order to be able to do that. We'll also move very rapidly into a delivery phase with a delivery plan for demonstrate to the board how we're able to hit our priorities collectively between the partners. And finally, we will start to give thought to the next iteration of this document, which has to be completed by the 31st of March for the next 5 years ahead, and considering the learning from this process of how we could improve and do it better collectively. Nothing else from me, but very happy to take questions or comments from colleagues on the board.
Thank you very much, Sam. And colleagues, comments and questions, please. Alex.
Just a comment of support. Berkshire Healthcare Board endorsed the plan, and Sam, as you know, very supportive of the plan. A lot of hard work's gone into that. Thank you for the board summary that you provided. It was very helpful. I think it's useful, isn't it, that we can iterate the plan and annually refresh it, given the financial challenges, particularly going to create some hard decisions around priorities that sit within the joint forward plan. So I think that's part of the refresh work. We'll just need to keep a close eye on as we go forward. Thank you.
Thank you. Ilona and then Graham, please.
Thank you. Thanks, Sam. Really great to see the document reach this stage. Very happy to support its publication. When you were going through next steps, the one I was listening out for and didn't catch was around how we track and monitor progress. So you talked about going into a delivery phase. Are you able to tell us a little bit about plans for how we hold ourselves to account for that delivery phase and make sure we're doing what we said we would do? Thank you.
And Graham, can I bring you in first and then we'll come back to Sam? Thank you.
Yeah, thanks, Priya. Thanks, Sam. Yeah, our board also welcomed the document and supported it. they had some reflections on the next iteration, Sam, on the document, and I guess their thinking was really about how can we make the thread that connects what's in the ICS joint board plan and what is in the organisation strategic document more clearly aligned. But we'll write back to you on behalf of the board just to set that out. But we were very supportive of this plan and looked forward to further iterations. Thanks.
Thank you. Over to you, Sam.
Thank you. Really helpful comments. Alex, thank you. And Graham, thank you for confirming your organisational support. I should have said in my opening remarks that it would be really helpful if the board could note its thanks to colleagues from those organisations who have worked incredibly hard on the production of this document. It is both joint in name and in production. So the amount of effort that has gone in from partner organisations to producing this has been really impressive and a genuine joint effort and endeavour. I agree, Alex. We know, I think, where we need to focus our next iteration and what needs to be further strengthened for the next version. Graham, taking your comment, I think absolutely spot on. The connecting thread between the ICS strategy, the joint forward plan and organisation level plans and delivery is clearly crucial to making all of this work and work effectively. And I think we can still continue to improve our approach to that. Ilona, your question on delivery, I think is absolutely very, very helpful. You're aware we have recently established our delivery PMO. It's a single unified PMO for all of our change and transformation work. We've been very thoughtful at a project level to tag work which aligns to the JFP or the ICS strategy or the operating plan so that we can cut and filter our progress reports and delivery through whichever lens best reflects where we are with that work. That also is a work in progress, but I think will really pay back actually as an approach as we get further through the year to see where we are making the progress we need to and also where we might not be. I hope that helps answer your question.
Thank you very much, and thank you for those very helpful comments and the inputs that have brought us to today's opportunity now to approve the plan that's been put forward. May I have confirmation? Thank you. Good. Let's move then to Emma Boswell and an update for us on our work with our VCSE colleagues. Thank you, Emma.
Thank you, Priya, and good morning, everybody. And I'm Emma Boswell. I'm the Director for Partnerships and Engagement and the Place Convener for North East Hampshire and Farnham Place within the Frimley ICS. I've also got my colleague here, Philip, who's joined me, who's the Chief Executive of Involve, one of our voluntary sector organisations. So thank you, Philip, for skipping out of the commitment you were in to come and join our board conversation this morning. So the way we were going to play this, we were just going to highlight some of the information that was put within the slides and share some of the journey we've been on together on developing our voluntary sector alliance across Frimley, and then hold some space for conversation at the end, which Philip and I hopefully will be able to help respond to. So thank you, Ollie. I'll just skip through these. If you move to the next slide, please. So really just wanted to restate that as a system, we are committed to building sustainable partnerships with our voluntary sector colleagues across the system. We really are focused on creating an alliance that supports further development of these relationships and particularly supporting our voluntary sector colleagues to be a strategic partner in the work that we do, with our focus on reducing inequalities and creating sustainable services. It's an ambition in our ICS strategy and also links back to the joint forward plan that Sam just presented in terms of how do we work better together with all of the partners across our system, all of the capacity and capability that we have to support our communities. We also just wanted to say that we have really strong foundations that we're building on. So we have lots of well-established relationships and programmes of work with the voluntary sector. We have our integrated care partnership, of which our voluntary sector colleagues are key members of. We commission services directly for communities from a range of different voluntary sector organisations. We have a number of innovation programmes in place as well. And we know that the voluntary sector is well embedded in a number of our portfolios, such as our children and young people and our mental health work as well. We also have really strong place-based partnerships, and very often our relationships with our voluntary sector colleagues are hyper-local, working together in really local places with communities and voluntary sector to make a difference. So if we move on, please. Thank you. So I think we just wanted to pick out a few key themes from this slide. Together we've been working on, so why would we have a voluntary sector alliance for Frimley? What does it mean? Notwithstanding that there is guidance around this, but actually what does it mean and matter for us within our system? And some of the key things that we've been thinking about together is, well, a voluntary sector alliance could help us to realise the full potential of the sector. So bringing people together, sharing good practice, strengthening the voice of the sector. It also will help us to unlock the capacity and joint resources that we have between us. I met last week with a number of voluntary sector colleagues in one of our places who were kind of starting to share with, well, we do a bit of that with that community as well. How could we jointly share our information? How do we signpost better between us? And also, and perhaps most importantly, about how do we build those really strong partnerships with the voluntary sector colleagues who deeply know our communities, who work with them every day, who are there tackling inequalities and engaging with our most vulnerable and our seldom heard, and how do we ensure that we can use that skill, that expertise and knowledge in the way that we work together. If we move on, please, Ollie. So it's fair to say we've faced some unique challenges here in our geography. We have 3 counties. The voluntary sector has never needed to be organised on our system footprint before. So we've got lots of people who are working hard on developing their relationships and partnerships across the system. And also we've recognised that we actually have a lack of understanding in some parts of both the NHS and in the voluntary sector about how we all work. What's the boundaries within which we work, and how do we understand those better? We have no mechanism to give one organisation the single mandate to step forward as perhaps some other systems would. And we also know for some of our voluntary sector colleagues that they have feet in other geographies as well. So how do we help them really feel part of our system, but be mindful of the pull on capacity and limited resources that are there? We also know that in line with all other services, the voluntary sector is really stretched post-pandemic, the cost of living crisis, inflation. So we're all facing the same challenges, and better to face those together than try and face those separately. Thank you, Ollie. So we've done a lot of work together. So we have done work together thinking about what are the 5 components of successful alliances. So focused on building our strong relationships, starting to create a shared vision and values. We have a voluntary sector leaders group of which Philip is part of, which has been working together over the last 18 months. We're now evolving that into our design group to take the work forward, and also really thinking about our principles of joint working. We have been able to secure some funding for a 1-year post to support our voluntary sector colleagues, and that will sit out into the voluntary sector and not with the ICB or health, to really help progress our work and establish our alliance. I know, Philip, you'll probably make some reflections on this, but it has been a long, slow journey. So we've had to take quite a lot of time on building those relationships and understanding our challenges. And it's been difficult to progress at pace. But I think with our resources now, the ways of working, and with some additional support, we should be able to motor much quickly. Next slide, please, Ollie. So together we've been thinking about what's the possible model for supporting an alliance, recognising that our voluntary sector colleagues work in streets and neighbourhoods and places. They support thematic pieces of work, so Bernardo's with our children and young people. A number of our mental health sector colleagues are working with our mental health provider collaborative. And how do we pull all of that together, and what would be the benefits of a strategic alliance, and how do we use that to support the way that the sector wants to work? So this model here is an emerging model. It's one we want to co-design together with our colleagues across the system, but really starting to be thoughtful about how do we pull together the work for maximum benefit. Thank you. So we've talked about the development funding that we've agreed. We've had a number of expressions of interest in from our voluntary sector organisations to host this on behalf of the system and to do the work together with all of our other colleagues across the system. And we are just about to land who's going to be hosting this resource to drive us forward. So thank you, Ollie. I won't go through the details. So we have a timeline here around the bit that we're in right now, which is about resetting ourselves together as partners in the establishment of the Alliance, then thinking about sort of exploring the co-design of the Alliance and the workshop that we want to take, and how do we do that together with others. Thinking about the mechanisms that underpin our commitment to joint working, such as a partnership agreement, and also continuing to support the fantastic work that's already in place across all of our places in Frimley. We'll move into implementation, and then in March to June next year, we'll be looking at reviewing where we've got to. So what progress have we made? What successes have we had? What challenges do we still need to pay attention to? If you move on to the next slide, Ollie. So this was just some examples of some of the work that we've been doing in Frimley, which really just is a tiny amount of some of the work that we do. Ollie, do you want to take the slides down? And I thought I'd just share a couple of personal reflections from the time I spent with some voluntary sector colleagues over the last few weeks. Then I hand over to Philip for your reflections and contributions. So one of the things that we really talked about as a co-design group is that, do we understand each other's worlds? And I was really clear that I don't think I understand how our voluntary sector is organised and works, and the pressures and challenges. And people agreed to undertake some leadership exchanges, which has been fantastic. So I went and spent some time with some voluntary sector colleagues. A few things that came out from that for me was, one, just how flexible and agile we need to be in whatever we build, so that we can truly hear the voice of the very small, hyper local voluntary sector organisations, as well as work together with the bigger organisations and across the Frimley footprint. So, for example, a family drop-in centre in one of our places was saying, I'm not sure that coming together to the centre of the patch for a big event's going to be the best use of our time and support the communities in the way we want to, but what we would really like is to be able to come together with other organisations in our footprint so we can understand and signpost people better. So a big piece of work on understanding each other's worlds, and also that we need to have a broader set of people in some of these conversations, particularly our local authority colleagues, and bringing them into the co-design group. So we've got that real sector, health and local authority relationship in making our connections. And finally, about how do we truly harness the power and passion of this sector in the most positive way. I'm always blown away by the contributions that they make, the way they support our communities, and the information and the power that they hold to make a difference to people's lives. So they were my personal reflections. Philip, shall I hand over to you for your reflections?
Lovely. Thank you, Emma. Yeah, thank you for, first and foremost, for sort of a very articulate and comprehensive overview and update there of our journey today in building the VCSE Alliance across Frimley. I think you're right. I think, you know, we have had a slow start, but I guess what that has done in many ways is it's given us the advantage from many of the CVS, so the Council for Voluntary Services, the leadership organisations that sit within each of the place areas, to look at what else is happening within other ICS systems, and to look at what kind of models might work well for Frimley. And I think that's where we're at now, as you suggest, really looking at a kind of a model that would work right for Frimley. It is a unique footprint and it does have challenges, but they're, you know, so do many of the other ICSs that sit around us. And as I say, there's great learning that we can take from that. I think what we do have is a universal kind of commitment from the infrastructure organisations to work collaboratively and to really work hard to bring lots of the micro organisations that have really great granular neighbourhood insights and data to the table, and to really enhance conversation strategy and partnership into the future between our health system and the voluntary community social enterprise sector. And so we go on, really, we go on with that commitment, we go on with the enthusiasm and the appetite to do something special, because ultimately, whether we are health professionals or whether we are working within the voluntary community social enterprise sector, we are here for the benefit of residents, and we're here to do our best for the benefit of our resident population. So, and I think that is what unifies us. And for me, that's the thing that will help to drive this forward. I think one of the kind of final reflections from me about a key challenge, I think, is how we're going to buy almost, and when I say buy, I don't mean financially speaking, but how we're going to bring small organisations, charitable organisations into the conversation in the first place. Frimley is quite a large space. If they're actually working with a very small geography, perhaps even a neighbourhood within a borough, for example, helping them to realise how important their voice is in our conversation, I think, is going to be one of our greatest challenges. Again, I think we have insights. I think we have learning from other ICS areas, which we can bring to the fore, which we can utilise to really mobilise and to help our sector partners to understand their value in that conversation. So I'm really looking forward to it. As I say, we have a unified commitment as CVS organisations to working together, to working with you good people across the Frimley ICS system as well, and look forward to our ongoing journey.
Thank you, Philip. Shall I hand back to you, Priya?
Thank you very much, Emma, and to Philip, thank you. Comments and questions then, please. Paul first.
Thanks very much, Emma and Philip. That's really brilliant to see. I think the voluntary sector has got an enormous role to play, both in individual communities, but also across the system potentially, as a key part of the transformation programme for Frimley, and in some ways it's a relatively untapped resource in the context of the NHS. And it was great to hear you, Emma, talk about that sort of culture, kind of crossing that culture gap, if you like, in terms of the conversations. I sometimes think we ought to have Duolingo for the relationship between the NHS and the voluntary sector. And I think the kind of key kind of objective here is to think about what really good looks like, both in terms of enabling and supporting small local community organisations to do the great jobs they do in areas around prevention and healthy living, as well as the role of voluntary organisations as part of the contracted supply chain, where I think there's huge delivery potential as well. So, you know, with that, I don't think this doesn't need answering now, but I think almost the next iteration for the group is to think about really articulating what that success feels like within the context of the Frimley footprint, and very happy to offer our help and support from an Age UK point of view to help make that happen as well. So just really great to see this getting to this point now. Thank you.
Thank you very much, Paul. Come in, Safina.
Thank you, Priya. Brilliant. Really exciting, Emma and Philip, to see this at this stage. Just a couple of reflections, and I know, Emma, we've talked about this in terms of underserved communities and marginalised communities, so that intentional inclusion around engaging with communities that are easier to kind of ignore. So, and I think that's in there somewhere, but really want to kind of reiterate the importance of doing that intentional inclusion. There's also something around the kind of co-production and co-creation of understanding that in that room, is there people with lived experiences and the diversity in that room, and the benefits of co-creating with diverse people. And I'm sure you've looked at that, but that was my other comment. And then that creating that loop of engagement. Often what I hear is people you know, we engage with communities and we get people involved, but we don't close that loop in terms of feedback to them and what has that engagement resulted in. And I think that's a really important kind of point when we're looking at engaging. So just a few reflections from me.
Thank you very much. Back to you, Emma and Philip.
Thank you, Priya. Oh, sorry. I mean, are you happy just for me to offer a reflection there? Because I think one of the things to recognise is we're not starting from a position of a starting position. You know, we already have advanced relationships with the VCSE across our respective patches. That's the reality. And pulling on your point there, Safina, about our communities, the diversity of our communities. Actually, the call I've just come off is around community cohesion and the importance of that. that. And, you know, we're just planning a cultural event in Bracknell Forest at the moment. And that's just an example of the local authority working very closely with the VCSE within our local authority area to really celebrate diversity. And I think that's one of the things that I would say, you know, it's how we all coexist and how we all work together. There's already a lot of partnerships that are established across our local authority areas. And it's not how we reinvent the wheel, it's how we're clever with what we're doing, because the reality is, as you guys within the health system are pushed for resource, the same is said of the VCSE. So it's how we are intelligent in our use, in how we align, how we work together on particular priorities, so to strengthen our communities, improve well-being of residents, all of those kinds of things. So we're not starting from a position of nil. We're actually already quite advanced. It's just then how we wrap the ICS around, if you like, the existing systems.
Thank you, Priya. I don't think I'll add anything to that fantastic summary. Thank you, Philip.
Brilliant. Thank you very much, both, and for all our input and comments, and really good to see this now progressing at pace, which I think is what everybody has wanted to see. So fantastic. Good. We're going to move then to our next two updates. The first is on health equalities, and the second on our system freedom to speak up report. So thank you very much. Starting with Dr. Lalitha Iyer and then on to Safina Nadeem. Come in, Lalitha.
Thank you. So I'm Lalitha Iyer. I'm the Chief Medical Officer for the NHS Frimley. And I just want to take you through a journey and give you a few examples of the work that we've been doing both at system and at place. Next slide, please, Ollie. So I just wanted to start off by reminding ourselves as to what health inequalities were. So these are avoidable, unfair, and systematic differences between different groups of people. And there might be many kinds of health inequalities. And so when we talk about it, it's really important that we are clear on what measure is unequally distributed and between which people, which groups of people. And why do we need to tackle health inequalities? It's a matter of fairness, social justice, and we know that millions of lives have been lost because we haven't tackled health inequalities. Next slide, please, Ollie. This is a reminder of our 6 ambitions, and as earlier speakers have said, our goal in the ICS strategy is to increase healthy life expectancy and reduce health inequalities. And we want to do this by work both at system and at place. And I just want to remind ourselves that our motto is not to see health inequalities and prevention as a standalone program, but as a golden thread that runs through every program of work that we have within our ICS. And our priority will be to ensure that we target those who have the greatest need and the poorest health and well-being outcomes. Next slide, please. This is again a reminder of a national approach, which is called the Core 20+5, where this is an approach that helps us deal with health inequalities at a system level. The cohort identifies 20% of the most deprived people nationally, that is those living within deciles 1 and 2. But as we are a fairly affluent ICS, we've taken the decision that we will look after our people in deciles 1 to 4, which accounts for 20% of our system population rather than the national 20% alone. So we've gone larger and wider because we want to deal with our people and help tackle health inequalities. And we're also working to identify plus groups between system and place. And plus groups essentially are groups which may not be represented in the 20% deprived, but are specific groups which need targeted action in order to help them access services within our ICS. There are also 5 clinical areas at the bottom of the slide, from maternity to hypertension, COPD, and so on. Next slide, please. So this is some of the work that has happened so far. Some continue in progress, in evaluation, and also the work. So fuel poverty was something we took really seriously last year. We had a fuel poverty summit. We identified through our shared care records to 56,000 people who were at risk of fuel poverty with winter approaching. There was a lot of work at place in order to support these people with the support of local authorities, housing councils, and so on. And this has set us up in a good place because we are already looking at how we can identify these people proactively right now before we approach winter and put support in place for them. The digital health management program is well embedded now. It's working with local authority and Office of Support. It is a nationally funded program. And the aim of this program was to focus particularly on those from the Black, Asian, and minority ethnic groups and the more deprived communities to access and complete weight management intervention. We were also asked to focus on the younger age group and men in particular. I just want to note that at one point, we were the highest performing system in terms of uptake. I also want to note that this is one of the many approaches we have on weight management. We are aware that this is more accessible to some people who may be more digitally literate and not for others. However, it frees up capacity then for those residents who may not be digitally literate enough or digitally excluded so that we can give them the additional support they need. Social prescribers can also support those who may be digitally excluded and connect them to local office. We've also got easy read information for people with learning disabilities, and this is on our public website. With regard to smoking, I just wanted to say that smoking is a leading modifying risk factor responsible for health inequalities. Smokers are 36% more likely to be admitted in hospital. They are twice as likely to be readmitted within 30 days. We also know that pregnancy is at a higher risk if one smokes, with high-risk outcomes such as stillbirth and miscarriages. And with patients with mental health, we know that smokers do far less well compared to those who do not smoke. So there is a program of work that we've undertaken at FHFT for in-house inpatient and also a maternity program. So the program works in conjunction with the community-based offers. So you detect, you advise patients, you start them on smoking cessation treatments, and as they go out into the community, they have continued support to access so that this is a sustainable program. Next slide, please. So on the left of the slide, we talk about NHS health checks. Essentially, these are health checks for people between the ages of 40 and 74 who are generally well. They do not suffer from any of the diseases like cardiovascular or kidney disease, for example, but the check aims to identify problems such as high blood pressure, perhaps, at an early stage so that they can be treated early and avoid risks of, say, perhaps having a stroke. Similarly, there are learning disability health checks, and we are improving in all these markers. And we were, in fact, on learning disabilities, one of the fourth highest achieving ICB within the country. On hypertension, we have an ambition to reduce the number of strokes and heart attacks by over 200 per year. In order to do this, we've got a system-wide hypertension prevention board. We link in with local leadership. That is not just health partners. Every place has a hypertension coordinated work plan. The largest improvements we've seen has been within our ICS. We had a practice who has more than 80% target and was nationally commended that they had reached this target well before we even started winter. We also want to continue to strengthen our relationship with community pharmacies, and there are a lot of community hypertension pilots. And the next two slides, Ollie, next slide, please. Next two slides talk a little bit about this. GPs are identifying patients potentially at risk, offering the use of blood pressure monitors to take home and measure their blood pressure. We are piloting a system where remote blood pressure readings are entered directly into patients' clinical records. And using our system shared care record means that we can proactively manage these patients. There was we've developed easy read leaflets that you can see a little bit of below, which is an easily accessible and understandable format for our patients with learning disability. It's also beneficial for other people. We have the community hypertension bus pilot, which went through Bracknell, North East Hampshire, Farnham and Surrey Heath and identified people in the community who had hypertension. Next slide, please. You'll also see that there's a link to the Hope Hub below. Hope Hub was so this gives us an example of how we can overlay detection of hypertension and other preventative measures on existing services. So Hope Hub exists at the moment for those in poverty, people who are homeless or at risk of becoming so, and it supports them for as long as they need, helping them progress towards independence, training, volunteering, employment, and so on. So at this Hope Hub, we then hosted a blood pressure monitor for about 6 weeks, supported the staff, supported the service users, and this meant that we reached vulnerable people, high-risk cases were identified, and it has been viewed as a great success, and now it's integral in the Living Well program. Next slide, please, Ollie. And I just wanted to finish with 2 slides of 2 places. There's work going on in every place, but I have chosen North East Hampshire, Farnham and Slough because we know that there are pockets, larger pockets of deprivation within these 2 places. There's a lot of information on this slide and I just will highlight a few of them. Walkabouts to the most deprived areas of the key people in health and care, such as PCNCDs, counsellors and housing officers, is a really good way of enabling understanding of the real challenges faced by the residents. Strong partnerships with the borough councils across North East Hampshire and Farnham, the voluntary sector, public health and the 5 PCN teams is really important for us to achieve our aims. A needs assessment for communities such as the Nepali and the veteran population has been completed in June. Health and physical activity surveys been carried out, and this has then enabled a lot of actions such as stop smoking services, COPD, preventative measures, and Tai Chi, for example, community classes, and so on. There also seems to be a theme in all places where schools are quite seen as an important part of educating. So meetings have been held with head teachers, presentations given to the head teachers forum on healthy weight, physical activity, and so on, gathering insights, exploring outreach work, and so on. And the other thing that most places are focusing on is tackling low-level mental health issues. It's really important when mental health issues start that we deal with them early on. Very often, residents are not aware of the help that they can seek. And so there's been a working group supported by a communication team. Questionnaire was sent to primary care and community teams to raise awareness of simple things like talking therapies, what are the services to treat low-level mental health, and so on. And North East Hampshire and Farnham is happy to report that their referral rates to psychological therapies are actually back to pre-pandemic level. One thing that has been done that's slightly different in North East Hampshire and Farnham is also the HIV pilot. So in February, during the HIV testing week, the Solent Sexual Health Trust and Hampshire County Council worked to drive late diagnosis HIV down, to promote normalization of HIV testing and identify an HIV champion for this area. So they texted about 16,000 people, and the team are working with the patient partnership groups and have now extended this to 6 other GP practices to enable people to be able to talk about HIV, get the testing done if they are worried. Next slide, please. So this is a little about Slough. The themes continue, and I just wanted to touch on again the tackling low-level mental health issues with a particular focus. And the themes that emerged here was that there is certain stigma associated with some cultural groups about seeking help. There's not only a lack of awareness, but some traditional practices amongst ethnic minority groups, which has meant that they are not seeking help when they need to. We know that Slough is an outlier when you look at the percentage of access to talking therapies. And it is understanding these key differences that will then enable us to provide services which are specific to diverse communities we have when we create our clinical services. And again, the second bit of work, the multi-generational house pilot, is one that caught the national eye, where health checks were offered within the households for people where they had not accessed childhood immunization, for example. And this meant that 68 extra immunizations, for example, were conducted within a pilot of 2 weeks, because we were going to people who were not reaching out to us, and therefore identifying blood pressure control, diabetes checks, asthma checks, and so on. And the second phase has started now, where based on less access to cough indicators, clinicians are going in and also then providing help with the need as may arise. We then have also a digital literacy program, as we know that there are many who may be digitally excluded. So there are 2 cafes across Slough which have opened to improve access to the internet, 16 workshops or so, and more than 120 participants. And the voluntary sector has helped with this to improve use of digital services within the NHS and to improve health and well-being. So I want to, next slide, please. I want to conclude by saying that as we move forward, it's really important that we continue to remain focused and improve system and place, enabling one another. It's really also for all of us to remember and understand that we want integrated cross-sector working. We want a system where responsibility for action is distributed beyond health partners to local government, wider stakeholders. We want to be seen as a system that has a two-way approach of engaging with communities, where we may share key public health messages to our public, but also listening and learning from them to understand how we can do the best for them, so that they can have equitable access, excellent experience, and optimal outcomes. I think, Chair, I will stop at that point.
Thank you very much. Thank you. A lot of information there. And yes, I share the claps that I can see on the screen there. Thank you. Any immediate comments or questions? Okay, thank you very much, colleagues. This is Pan's sister work, as you say, Lalitha, and it is very good to see that join up having that impact in effect. Continuing that theme, Safina, over to you for our Speak Up report.
Thank you, Chair. I've got a presentation that hopefully, yeah, brilliant. Thank you, Ollie. So just to let people know, I lead on equality, diversity and inclusion, but I'm also the Freedom to Speak Up Guardian for the Integrated Care Board. And this is our first kind of Speak Up report we're bringing since the formation of our ICB. I'm assuming everybody's read the kind of report, but I will be picking up things from the slides and then leave some time at the end just for any questions or thoughts. So people will know that the role of Freedom to Speak Up was directly recommended from Robert Francis's report into the Mid-Staff's NHS Foundation Trust. And all NHS trusts have to have a Freedom to Speak Up guardian within their organisation. And when the ICB was formed, I was appointed the Freedom to Speak Up Guardian for the Integrated Care Board. So although each trust, the guardians provide reports for their own respective boards, this is a joint report with all 3 NHS trusts in our system, and including us as an ICB. And we have to submit our Freedom to Speak Up data every quarter, and this is from our Q3 submission for 2022 to 2023. The next slide, please, Ollie. So whilst writing this report, although I've been in post since July last year, there wasn't really any guidance for ICBs and ICSs around Freedom to Speak Up. And then, as I was writing this report, we got some guidance from NHS England and then National Guardian's Office about what ICBs should be doing. And the positive thing is that actually we are ahead of the game with this, and some of the recommendations that NHS England and National Guardian's Office put forward, we're already looking at, and myself and the other 3 guardians in the system are working quite collaboratively and closely, and have been since January last year. So that's refreshing. So just a reminder in terms of what ICB should be doing. we should have a freedom to speak up guardian for ICB workers internally by January 2024, 30th of January 2024, and we've already got that in place, which is me. Again, really positive that we've been doing that. Freedom to speak up for primary care workers over the next 18 months. We've been having conversations since last year around our approach to freedom to speak up and primary care. So again, really kind of ahead with that recommendation. And then looking at an ICS, what should we be thinking about? You know, how do we as a board gain assurance that everybody's has arrangements around speaking up in all our 3 trusts, and how we can adopt a policy that's been set by NHS England and the National Guardian's Office, and having a standardised policy across the system and an improvement tool. So some of these things that we're already looking at and are already in play. You know, again, really pleased that we've been looking at addressing some of these recommendations. Can I have the next slide, please, Ollie? So just in terms of data, this is again from Q3 for the 3 or 4 organisations brought together. The number of cases brought to the Freedom to Speak Up Guardians, 105 collectively. Number of cases raised anonymously was 6. And then that kind of patient safety and quality, 27. We've got other areas that we've the speak up cases have focused on, which is well-being, which was quite high, bullying and harassment, inappropriate attitudes and behaviour, and then people who felt that there's a detriment for them speaking up with 3 people. So what this kind of tells us is that initially when we looked at when Freedom to Speak Up was brought in, it was really looking at patient safety and quality, but what we're seeing more and more of, and the other guardians will say this, is that elements of that kind of behaviours and bullying and attitudes are really high, which is something that we need to think about. Can I have the next slide, please, Ollie? So this is just a national picture from a recent report looking at the staff survey and speaking up, and it just tells us in terms of where we are through the staff survey results. And this is a national picture. We've not done anything as a system picture yet, but this is a national picture saying that actually, you know, there is decline in our scores around speaking up, and I think notably around people raising concerns related to clinical practice has gone down. So something again for us to think about, and just some other evidence that's there. What's really important to look at as well is that the Freedom to Speak Up subscore correlates positively with CQC rating. So if you have good speak up scores, you're likely to have an outstanding or good Care Quality Commission rating as well. Next slide, please, Ollie. So just a few key points from the data that the other guardians wanted to raise as well and bring out. I've mentioned behaviours in relationship and bullying harassment is increasing. And I think what we want the board and staff to realise is that actually bullying and harassment does directly impact on the experience and patient care. So really important that people understand that. How does this help then in terms of if you want to create a compassionate and inclusive place to work? How do we make sure that people feel safe to speak up, but also their issues are addressed as well? There's also voices that aren't being heard, and I think the other guardians were really clear to really think about people that don't speak up. And we know that certain people for protected characteristics like Black and minority ethnic people, disabled colleagues, people from lesbian, gay, bisexual, trans backgrounds don't speak up. So how are we hearing and encouraging their voices to come through? We have anonymous cases, and what that means is that we often can't give feedback or ask further questions. You know, we ideally want to be in a place where people feel confident to raise issues without being anonymous. And then looking at that line manager role in terms of making sure that people feel encouraged and valued when they do speak up. Next slide, please, Holly. So these are the cases that staff have been courageous to speak about, but you know, where are the other opportunities for people to speak up, like via our staff networks, for example, and is that being captured anywhere else? And we, you know, to create this kind of bigger picture that we have. The board is also asked to support joined up work. So like I said, myself and other 3 guardians are looking at a consistent approach around reporting, but also training for senior leaders. So at the moment we have 3 areas of training that's recommended by the National Guardian's Office, so which is speak up for everybody, listen up for senior leaders, and then follow up as well. So it's really important when people are speaking up that there is this view that things are being followed up and actioned, otherwise people will stop speaking up. Yeah, and again, thinking about how the board role model freedom to speak up in their everyday interactions, and like Lisa was saying about health inequalities, this is not something in addition, it's part and parcel of everything that we do. And it's really important that we role model behaviours that we expect. A joined up approach across the ICS, and then, you know, how do we support people who are suffering a detriment? We did say there was people who felt that there was a detriment. There is a national programme around this for people who are suffering a detriment through speaking up, but we're looking at actually a localised approach as well to this. Thank you. So really thinking about, you know, speaking up can you know, is something that we need to embrace and create a culture that is okay and it's positive when we speak up. So how do we make sure that we do that as a board, and then enable kind of that psychological safety within teams to feel that they can speak up, and making sure that if things go wrong, it's a learning for everybody. We stay away from a blame culture, but actually what is a learning for everybody, so we can promote that positive workplace and culture for everybody. So next steps, we're going to continue to work collectively with the other guardians to improve culture, speaking up where it's welcomed and used for a tool for improvement. We are collecting equality monitoring data to understand who's speaking up and who isn't. I think we need to make that a little bit more robust. We are in talks with around developing an approach for speaking up in primary care. So we've had a conversation with Sarah and Caroline Farrar and other clinical directors around what is the best approach to look at freedom to speak up in primary care. We have planned a board seminar around freedom to speak up as well, I think next month. Local authorities don't have the same speaking up arrangements as freedom to speak up, but have they got an arrangement where people can speak up, and how do we make sure that we capture some of that in our learning as well, and then continue to raise issues with organisations in our system. So if people come to me about their organisation, I'll make sure that that's fed back and addressed. And then I mentioned the new policy, to make sure that we've all adopted the new policy and the improvement tool over the next 3 years. Is that my last slide, Ollie? Thank you. Happy to take questions. We've got time, but more comments.
Thank you, Sabina. Any initial comments or questions from colleagues? Rachel, come.
I just wanted to ask about the intersection of this policy with other HR policies where there might be some overlap. And the reason for asking the question is because the directorate that I'm responsible for in my local authority incorporates staff from NHS organisations as well as local authority employees, and it's been an interesting challenge, useful, positive, to think our way through the freedom to speak up arrangements and respond to those appropriately at the same time as managing some things which have an HR dimension, such as a grievance, for example. So I'm just interested in thinking about how this sits alongside those other policies across a range of organisations. Have there been thoughts about that?
Thank you, Rachel. I'm just going to gather in all of the comments and questions, and then we'll come back to you, Sabina. So Ilona, then Fiona and Caroline. Thank you.
Thanks. Thanks, Sabina. Really helpful presentation, and good to get an update on what's been going on in terms of the data. On the data specifically, I wondered if over time it's possible to do any benchmarking. I know we shouldn't expect too much of it, but just to give a sense of whether the numbers we're seeing are broadly similar with other similar sized systems, or so we can get a sense of are we an outlier or not in terms of the numbers who are speaking up. And I know it's hard to get a sense of what would we feel alarmed by versus comfort is the wrong word, but what's a sign of a psychologically safe culture in terms of the numbers. So that was just one thought. And then my second one was really I think we've got Prash here today, really interested in any early thinking about where we think we'll go on the primary care piece here, because that sounds like a good idea, but potentially quite complicated in practice. So and this may not be the time to do it, Priya, if we're running a bit short of time, but I was really interested in what our thinking is about how we'll take that strand forward. Thank you.
Thank you. Let's gather everything in, and then we can follow up as well. So Fiona, then Caroline and Sarah.
So mine's not a question, it's more a framing. So really welcome the report. Thank you, Safina. So we're working in human services, and what we should see speaking up as is not another HR policy or framework. It's absolutely about encouraging people when they're working in safety critical environments to be able to talk openly about concerns and safely. And actually, through the process, there should be an articulation and a discussion about whether something is a grievance or not. But we shouldn't automatically get ourselves tied up into knots about the relationship with HR processes, or etc. Because actually, what's really important is that we as leaders manage our own fragility and vulnerability in order to enable people to say stuff that might be difficult to hear in a way that won't automatically lead to a process and a formalization. And that's what we're learning. One of the and what I would say, Ilona, to your response about what's good look like in terms of numbers, as you develop a freedom to speak. I mean, I've worked in this territory for many years in a provider organisation. As it develops, it's a bit like complaints. The more you get, as people get used to doing it, you will see a surge. And we should see that as a gift of intelligence rather than a problem to be solved. And that's the framework I would recommend the board to have in this mindset, and all leaders across public service.
Caroline?
Just to support and build upon rather than repeat, two things. The System People Board has a group that pulls together in terms of learning around the intersection, because as Fiona said, taking that framing and then looking at casework and then learning together about have we got ourselves tied up in knots unnecessarily around grievance policies versus that. There's a learning approach to that. So just to highlight that there's a group within the System People Board. It's not the only group, but it's a place for some of that conversation. Second thing, just to support Safina, incredibly important work. As part of the next step, Safina, I think there was also the e-learning materials that we're all sharing with each other as well. There's some very powerful videos and very useful content that we're also sharing across organisations as part of our efforts moving forward.
Thank you. And a final comment or question from Sarah.
Thank you. It builds on kind of what Fiona and Caroline have said, and thank you, Safina, because this is really important work that you've been helping us to deliver within the organisation. And it was that piece around that interaction with the grievance policy. And I think grievance is always a word that I've found difficult to understand, because actually it's a relationship management it should be a relationship management policy. And what we want to do is encourage that early conversations, encourage feedback in the way Fiona talked about complaints. We need to hear from our staff, we need to hear from our patients so that we can do that improvement. And when it comes to the bullying and harassment and those relationship managements, we can't forget that civility saves lives. There's lots of important evidence to suggest that. So thank you, Safina, for all the critical work you're doing in this area.
Thank you. And Alex?
Safina, thanks. Yeah, agree, really important work. I think you nailed it around the role of the manager in terms of setting the culture for teams and speaking up. We know that in our provider trust partners, we've got quite a lot of infrastructure around freedom to speak up, including non-exec champions on boards. So I'm really keen to understand where are the gaps that the system can help with, and really get behind that. And if that's training, that's fine. I'm also really interested to understand the volume of speaking up that's going around individual partner speak up processes and coming direct to you, because that is a concern and would indicate in providers that's not working effectively. So just not in detail, but do you have large numbers, or is it exceptional when that happens?
And Emma.
Thank you. I was just thinking about how this really ties back to our Frimley behaviours and our 6 Frimley behaviours, and is one of the ways through which we're really focusing on embedding the cultures and the behaviours that we've designed through our Frimley leadership behaviours, and the connection back to the ICS strategy around leadership and culture. So I'm always trying to think about tying and joining the dots together, and how this is just one really invaluable piece of work that help us to continue to grow our cultural approach and thinking about speaking up and listening up and making a difference. So thank you, Safina.
Thank you all, really helpful and very rich comments. Safina, pick up what you'd like to today, and then we'll take much of that into our next update.
Yeah, thanks everyone, really positive. Just the benchmarking one, Ilona, I think Fiona said it, we should be worried if people don't speak up, and I think for me it's a real positive that people are speaking up internally in the ICB, but also I'm hearing from across the organisation as well. Primary care, I've had a conversation with Hugh on the board, and Prash as well, so we're looking at that, and I think it's going to be a really good piece of work when we get that done. And then the other bit around Alex, people do come to me, and I think what I'm reflecting on, that lots of people from Black and minority ethnic backgrounds are approaching me, which kind of tells me that how important it is to have diversity within guardians. And we know that's a national problem. We don't have representative guardians. So people come to speak to me informally. People have come to speak to me formally, but you know, it's things that are, I'm again encouraging, because that's my role within the organisation. But I am feeding that back to organisations if they need it. So it's not just staying with me.
Thank you.
Thank you, very helpful. Good. Let's move then to our board assurance framework, and over to you, Emma.
Thank you, Priya. So the board is today presented with the most current version of the board assurance framework, and it's here for review and approval. Just to remind colleagues that the board assurance framework sets out our principal risks to the delivery of our 5 strategic objectives, and helps us as a board to support us in assessing our progress and delivery of our strategic objectives, and more importantly, managing the significant risk to delivery of our strategic objectives. Within the latest version of the board assurance framework, we have taken the outputs of the May seminar session we had on developing our risk appetite, and thank you very much to colleagues who've commented and come back to me on the draft version that's been previously shared. So today the board is asked to approve the narrative risk appetite statement that's in slide 5 of the document. The board really wanted to develop a narrative statement to risk appetite, which really reflected us needing to balance the benefits of transformation with the challenges we face and the risks to delivery of those, and making sure that we had an agile approach to managing our risks to ensure we delivered our strategic objectives. So the board's asked to approve the narrative risk appetite statement in slide 5, and also to agree the risk thresholds that were set against the Good Governance Institute guide in slide 6. In addition, I just wanted to bring to the board's attention that there are 3 principal risks which currently sit outside of our risk threshold appetite, and that relates to strategic objectives of improving outcomes and reducing inequalities, our people and our financial sustainability. And within the document, you can see the risk analysis slides, which sets out the actions we're taking to mitigate those risks and to bring them within threshold. And also to note, 2 of our principal risks are within the threshold set by the board. I'm not going to go into detail, it's a long document and the board have had it, so I'm happy to take comments and questions.
Thank you. And colleagues, comments and questions? Just looking across. Ilona.
Thanks, Priya, and thanks, Emma. I know a huge amount of work has gone into this, and it's been a very thoughtful exercise. So really good to see it reach this point and get shared in our public meeting. I just wanted to flag that BAFs should be seen as kind of living, breathing documents. So yes, this one is here for us to review today, but I think, Emma, correct me, we're planning to bring this back on a periodic basis to the ICB, although it'll be the risk, I've forgotten what it's called. Integrated risk group, thank you, that will review it on a more regular basis. And just in governance terms, the audit committee has a role to be assured that the process is working effectively. But the BAF itself will come back here. What's your plan on that? Is it, I can't remember what your intention was, but I thought just let people know.
So there are lots of next steps, Lone, so thank you. It's a good prompt for me. So definitely one of the early next steps is to line in and add in a slide of the corporate risks that score 15 and above in our risk register to our principal risks. So that's the next step of action we will be taking. But also, yes, bringing back the board assurance framework on a quarterly basis to our meetings for review and challenge and check-in.
Thank you. And the final thing, and actually I just see Neil's hand has gone up. I'm really interested to check in with any partner members if the list of risks aligned with our strategic objectives feel to partners as the key things we collectively should be worrying about and making sure are captured on our agendas through the year. But perhaps, I don't know if Neil was going to comment on that, but maybe he can.
Come in, Neil.
I was going to, if my network holds up. Yeah, forgive me, everyone. Yeah, I mean, this is obviously it's a really good piece of work, Emma. But for me, it feels very like the ICB risks kind of organisation rather than necessarily a amalgamation of the significant system risks across all partners across the system. So I was just going to ask, is that in the next steps piece of work? Is that something we want to consider as a board?
I think it is exactly in the next steps, Neil, and I think it's one of those tensions and challenges that all ICSs and ICBs are facing. We're actually talking to our external auditors about any good practice that they've seen around board assurance frameworks, being able to pay attention to those risks that might sit within an ICB environment, most of which will involve and engage with our partners. So the way we've tried to establish our ways of working and our governance architecture is very partnership based. So the membership of our system boards and place boards, the membership of our principal assurance committees involving partners, and that should flow up and down through the board assurance framework as well. So I think some of our principal risks are framed more in the system than others. So I think it's part of the nuance and part of the next steps and development for us as an ICB and an ICS as we go through. So really would love to continue to work with our partner members on how do we keep iterating this and making it as thoughtful and as useful and live as possible.
Thank you, Emma. And our programme of work as an ICB is across our governance structure and our committee structure, and the BAF and allocation of risks into the committees will give us that cross-organisational approach, which is vital to being able to make this a worthwhile and important driving document. Graham?
Thanks, Priya. Yeah, thanks, Emma. I just wanted to say, I think it looks very good. We are, I think, going to spend some time on our board looking at it in a bit more detail. So I don't think we've got any formal reflections at the moment, but that is something we definitely want to do. Yeah, and I think there are some differences by the way this BAF is and how our BAF is, so we'll be reflecting on those as well. So,
it'd be great to have the learning from that, Graham, and happy to support any of those conversations.
Thank you very much. So we're seeking approval as set out by Emma. Do we have confirmation? Thank you very much, everybody. Good. Okay, let's move then to the performance oversight report. And Rich, am I handing to you first to lead us?
Please, Chair. Yeah. So I think Ollie has some slides to share. Thank you, Ollie. And we're going through them in a slightly different order, starting with workforce inequality and operational performance. We're presenting this on the day in order to try and get the most up-to-date position that we can, bearing in mind that particularly in operational performance, different data is available at different times, which means sometimes it's out of sync. But I'm going to hand over first to Caroline, who's going to talk us through the workforce.
Thanks, Ollie. If you don't mind moving the slides on, please. So 2 areas here just to summarise in terms of operational performance. Our view is still in the main on the performance of FHFT, and just some highlights here in terms of continued improvement on some of the key workforce metric areas, particularly sickness absence being lower than the regional average, vacancy levels improvement and now at the regional average, although with hotspots as you'd expect. Staff appraisal rates having increased as well and improved. There is, as not just with our system, but with all providers, the use of temporary staffing has improved in terms of strength and governance arrangements, the implementation of new controls and assurance mechanisms. And just lastly, to highlight the industrial action most recently through June managed well, and the system planning commences for the potential action in July. The performance data for BHFT and SABP is routinely scrutinised via the Bob system and Surrey Heartland system, so hence a quick overview of the key workforce metrics for FHFT. The System People Board, just by way of linked to the performance of our system, just to highlight the inclusion now of health and well-being as a key strategic objective and a set of metrics coming forward on that, and that we've done some work around the terms of reference for the System People Board to strengthen the oversight and assurance of the board in relation to performance oversight as well. Thanks, Rich. Back to you.
Thanks, Caroline. I think Sarah is going to talk next about quality.
If I can get myself off mute, and Rich, so thank you. I think it goes without saying all the things that we're highlighting in workforce and performance have an impact on quality and are linked, but didn't want to repeat things that either you or Caroline say. So just wanted to draw your attention to 3 things. National Quality Board has issued some draft early warning signs framework, which will allow systems and NHSE to have use early intelligence and data to identify quality issues, and it sets out 3 different levels of quality improvement and assurance monitoring around services that are provided within systems. And it's really interesting. A couple of our areas around us are part of that pilot, so we are looking to see how that gets implemented so we can do some adoption and what's different about what we do currently. The other thing really was to talk about C. diff. We've seen an increasing rate across the system, and we've been working together across the system to address this. We've got some significant efforts going on across all providers in relation to antimicrobial prescribing, which, as you can imagine, increased during the pandemic. And so we've got some other focus work in relation to urinary tract and catheter-associated infections. I'm really pleased to talk about a quality improvement programme we've managed to start to design and implement around essential standards of care. This programme focuses on ensuring those key elements of nursing care that include nutrition, hydration, and hygiene, infection prevention and control. These are really important for individual patients, but also should reduce the amount of associated healthcare interventions through the preventative nature of the intervention. So thank you.
Thanks, Sarah. And Ollie, if you were able to move on to the next slide, that would be great, please. So the slide describes the position as at May 16th, which is when our last fully validated data ends. But as Fiona referenced earlier, we've seen some real volatility of demand within the system since then, and that volatility is a driver of the intense challenge that we face in delivering consistent and improving performance. The extreme ED demand over the weekend of June 10th, 11th obviously has a knock-on impact on admissions and length of stay, and hence bed demand. A&E attenders now back above the 6-week average, we know from the very latest data. Ambulance response times have improved, but our ambulance providers are increasing their resource escalation levels in response to the pressures, and this in the background of primary care capacity, which we are providing more appointments than we ever have, with March 22 being the latest available figures, where we were 7% higher than the preceding March, which was itself the highest we'd ever provided for that month. So just an indication of the level of intense demand, the level of volatility within that demand, which is creating significant pressures on operational performance within the system. If you just move on, Ollie, aware of time, I will run through the 22-23 outturn position. So accounts have been finalised and audited. The top line there includes the full integrated care system position, including Surrey and Borders and BHFT, which are not part of the technical statutory Frimley ICS position. For that wider view, there was a favourable variance plan of 10.5 million on the second line there for the statutory ICS itself, which is Frimley Healthcare Foundation Trust and Frimley ICB. There was a £124,000 surplus against a break-even plan. If you can just move on to the next one for me, please, Ollie. Thank you. So that describes the same position with a different cut and a little bit of further details. The ICB position included some quite material cost pressures in mental health and learning disability placements, children's placements, CHC and prescribing, which have been mitigated by non-recurrent benefit, and that position includes a non-recurrent benefit in the FHFT position from land sales proceeds relating to Heatherwood, which were received during the financial year. And that non-recurrent basis on which we deliver break-even, if you can just move on one more for me, Ollie, thank you. So it plays into the 23-24 plan. So we have submitted a break-even plan, which has subsequently been approved by NHS England. Within that plan, there is material risk, including a need to identify additional cost savings valued at approximately £30 million, and the system is working rapidly to develop and implement a financial sustainability programme to deliver that efficiency saving. That's all I had to say, and I'm happy to take any questions on that, Chair.
Thank you very much to all who have presented there. Any immediate comments or questions? These figures and the discussions around them have been through board committees and I know have had significant scrutiny, so thank you very much, everyone. Good. Let me ask then, is there any, this is the section where we would address any questions from members of the public. We haven't received any this time. So may I ask committee members, is there any other business? No. Okay. Well, thank you to you all. That's been a really wide-ranging discussion this morning. Great update. So good to see that work. And a thank you to all those providing services across our system in very difficult and challenging times, but in a way that has received fantastic feedback. So thank you, everybody. Keep well.